Uh, Good morning to one and all. I'm Dr. Mubeen, Assistant Professor from the Department of Anesthesiology, Sri Lakshminarayan Institute of Medical Sciences. Today, I'm going to take a topic on snake bite management. Snake bites are more common and their management, if not treated properly, can be life-threatening. And as a no, as a ditto, not all snake bites are poisonous, but those venomous snake bites can kill a person if not treated properly. So coming to the objectives of today's class, we'll be having a class on first how the patient presents to you and what are the first aid mechanisms, because most of the time snake bite occurs in a field, house, or in a remote area. So shifting the patient from a remote location to your hospital takes time, and during that period certain first aid mechanisms are required. And what are the signs and symptoms to identify the different types of venoms, and lab investigations to prognosticate as well as to estimate the treatment and to rule out poisoning or not. Then actual therapy with anti-snake venom, and what are the consequences or adverse reactions associated with anti-snake venom therapy. Then how do you manage a neurotoxic envenomation, and also there are different types of snake poison. One is neurotoxic, the other is vascular toxic, and their management to be discussed. So these are the objectives for today's class. So coming to three major or wide varieties of snake poisons or types. First, the type, the family it belongs to. One is Elapidae. Elapidae, which is the snakes that come under these are cobra and kraits. Second one is Viperidae. Viperidae are vipers like Russell's vipers and soft-scaled vipers, sometimes even pit vipers. Then the sea snakes. Sea snakes belongs to Hydropidae. So Pidae belongs to snakes, and Elapidae, Viperpidae, and Hydropidae are the three most common envenomous snakes available in India and more common type of poisoning. So Elapidae, cobra and gates, once bitten, will lead to neurotoxic types of envenomation. So these snakes, once we get bitten by the snakes, the signs and symptoms points towards neurotoxin. So they affect them mainly the nervous system and both central nervous and peripheral nervous system. And signs and symptoms will be those along the signs along the neurotoxic types. Then Russell vipers and soft-scaled vipers will have hemotoxic. Hemotoxic in the sense it involves blood. So either there can be local swelling, hematomas, or even widespread hematogenic hemorrhage. So vipers will have more of blood-related or bleeding-related consequences. Then coming to snakes, they are myotoxics. Myotoxic in the sense they will lead to most of the time with so most of the time with muscle related, wherein there will be necrosis of muscle tissue and those side consequences like that release of all those muscle proteins, myokinase leading to kidney failure and other consequences, and mostly local necrotic lesions, wherein the muscle gets necrotic. There are more than 2,000 species of snakes in India, of which 300 are found, more than 2,000 snakes are found all over the world, and around 300 types are found in India, of which only 52 types of snakes are venomous, and of which there are around 5 to 6 lakhs of snake bites per year. So of this 5 to 6 lakh snake bites per year, only 30% are by venomous snakes, rest all by non-venomous snakes. So if we come to the photo here, we can see this one is a common krait or naja naja. So this one. So the first one is common cobra, naja naja. The next one is krait, common krait, which will be more towards the huts and roofs in the hutted areas, thatched roofs. Kites are commonly found. The third one is these two are vipers. One is soft-scaled vipers and one is the Russell's viper. So coming to clinical presentation, as I discussed above, there are three types of venomous snakes, and each type of venom will have different clinical presentation. So the patient can present in any of the four clinical syndromes with or without overlapping. So that means a snake can have both specifically neurotoxic, vasculotoxic, myotoxic, or just painful progressive swelling, or else there can be interlinking or intermingling of various syndromes. So if the patient presents with more of a progressive weakness, muscle fatigability, ptosis, or those kind of things are due to neuroparalytic or neurotoxic poison. Bleeding per se, patient is bleeding from various orifices, that is due to vasculotoxic or hemotoxic. Then third is myotoxic. Myotoxic, as I mentioned earlier, muscle death and muscle necrosis. Fourth type can be local progressive swelling that is keep on increasing in size and presentation as time progresses. Now the patient usually gets bitten in a rural or remote area. So what should we do as a first aid measures for these patients? So any bystander or even by the victim, this can be done, and it is done at the community level or the village level. So what first thing first, have a short history or ask what happened. So what happened, when was the patient bitten, where was he bitten, has he seen the snake, was there the evidence of snake bite, those two prongs is visible, fang marks are visible. Then you reassure the patient, tell him please don't move or don't exaggerate, hyperventilate or be anxious, relax, reassure that the treatment, if properly given, will be normal, and or also convince that patient that it can also be a non-venomous snake bite. Then immobilize the limb. Immobilizing the limb is very important, as a movement increases transfer of envenom from the site of bite to the whole body, especially vascular toxic poisons. Then patient should be on nil per oral or empty stomach till he reaches the medical health facility. Do not provide water or any coffee or any liquid or solid diet. If the patient is having some blister or some oozing bleeding blister site, leave the blister undisturbed. Do not poke it. Do not try to do all those previous old myths like sucking it and sucking blood from the bite and then throwing it out, or putting some coffee powder or some calcium carbonate powder over the bite marks. Then inform the doctor regarding any symptoms if developed at the site of bite or in general, like weakness, bleeding, pain, seizures, anything if happens, you have to inform from the time of bite till it reaches the hospital. Then remove the tight clothing from the bitten area. So if the patient is wearing pant, try to cut the pant at the level. For example, if he has bitten in the knee level, remove the pant above the knee level. Just remove the tight pant so that you can have visualization what happened. Do not move the limb rapidly. Immobilize the limb. So how do you immobilize the limb? There are pressure immobilization or immobilization like a fractured limb. So pressure immobilization, you start from, for example, the patient is bitten in the lower limb. Here you can see two fang marks. You start above the one joint above. So you give the pressure and then you immobilize by rolling the crepe bandage from above till below. And as you keep on moving, keep a wooden stick or a rod at the side of the limb and roll the crepe bandage over it. This improves the immobilization. This is the modified Sunderland method of immobilization. Then as the crepe bandage is rolled over the uh, slab or the stick, the limb gets immobilized. If crepe bandage is not available, provide a small wooden scale or any branch or twig in the outside, and then immobilize with tying to twines or threads over the upper and lower border of the joint, and then immobilize the limb. So at the healthcare facility level, what do you do? As you receive the patient, you first secure a IV access because he may require antivenom snake therapy or It can also, you may also require fluid resuscitation. You may be collapsing vasculitic, and early securing of IV access is much easier rather than when the DIC or bleeding sets in. So first secure a IV, large IV access. Then start fluid if the patient is in shock, hypolimic shock or septic shock or even distributive or cardiogenic shock. Depends upon the patient presentation and type of poison. Then admit all victims of snake bite and keep under observation for 24 hours. Need not be a venomous snake or non-venomous snake. As you hear, the patient is giving history of snake bite. Look for bite marks, and then as soon as he comes, you just admit and observe him for 24 hours. It may be an even non-venomous snake bite, but we may not be sure. So for 24 hours, we have to observe. There are something called as dry bites, which I will discuss later. Then provide first aid measures and supportive measures immediately. So you provide first aid, wherein you stabilize the patient, immobilize the limb, give fluids as necessary, take blood samples, and then you observe for signs of envenomation. The signs of envenomation will be dealt later or told later. Then, if required, you have to give anti-snake venom therapy as early as possible. If you find that a patient develops signs of envenomation, do not hesitate to start an anti-snake venom therapy. But you should have proper precautions while starting anti-snake venom therapy. It can have its own consequences. So coming to the signs and symptoms. First, examination of the bite site. Patient may present with a non-specific symptom because of anxiety like palpitation, sweating, excessive breathing, tremors, tachycardia, tachypnea, even high blood pressure. These are all anxiety related, sympathetic overactivity related. Sometimes patient can have even paresthesia and dilated pupil. These all suggest sympathetic overactivity. Then redness, increased temperature, persistent bleeding, and tenderness locally at the site of bite. For neuroparalytic envenomation, there are 5Ds and 5Ps symptoms. The 5Ds are diplopia, dysarthria, dysphonia, dyspnea, and dysphagia. Diplopia, double vision. The patient will try due to problem in the accommodation reflex or paralysis of those nerves. There will be double vision, diplopia, dysarthria. Patient will have pain or unable to move his limbs. Dysphonia, difficulty in speaking, dyspnea, breathlessness, and dysphagia, unable to swallow or eat. Then 2Ps, ptosis and paralysis. Patient will develop limb paralysis either at the site of local infiltration or generalized paralysis, and ptosis, that is drooping of eyelids is possible. Then paralysis, slowly the paralysis will increase as it will keep, as the venomation gets spread throughout the body, each muscle group will start to get paralyzed. So there will be paralysis of intercostal muscle and skeletal muscle in descending manner. So from up to down. Other side of impending respiratory failure or decreased response to stimulus, and breathing pattern will be very deep, slow, and not responsive, and the reflexes will be absent, and there will be leg lag. Patient cannot hold his head properly. He will have drooping of head or falling down of head in the back as you lift the patient. Then there can be stridor, ataxia, which are also can be seen due to paralysis of cerebellar nerve fibers. Then hypertension and tachycardia may be present. It is due to hypoxia here. Now, hypoxia-induced hypertension and tachycardia can be present. So, you perform bedside pulmonary function tests such as ability to blow a candle and patient's ability to speak continuously without having a number of words to be spoken without taking breath. So, we can have an assessment of lung function by work of diaphragm and intercostal muscles at the bedside level. And you can also ask the patient to walk 6 meters. Test all these things can be done bedside. You can use a spirometry bedside and identify impending respiratory failure. So if you find that the patient is going into respiratory failure, that means the muscles have started paralysis. So neuroparalytic poison has been, envenomation has started. You have to stop and take venom therapy as early as possible. In case of a child, there can be loud and husky cry. If it is absent, that means the muscles are getting paralysis, dysphonia is setting in, baby is unable to cry loud, and diaphragm vessels are getting paralyzed. So if the patient presents with neuroparalytic symptom, you have to refer immediately to IS center if intensive care support is not available, or you can, if you are in IS center, shoot the patient immediately to ICU and give atropine neostigmine injection even before ASV, because now we have to counteract the the nerve fiber uh, nerve paralysis and counter it with the neostigmine anticholinergic effect. Okay. Now you can see the patient here who is presenting with ptosis, bilateral, is unable to open the eyelids. You can see there is frowning, loss of frowning in the forehead because he is trying to open but he is unable to open. He is having ptosis. Here you can see complete ptosis. The patient is unable to open. You can only open with your fingers manually. It is possible, but the patient cannot voluntarily open his eyelids. This is ptosis. Now coming to vasculotoxic or hematotoxic bleeding. Here there can be either local manifestation or systemic manifestation. Local manifestation, wherever there was a bite, you can see this lady. Uh, the place of bite mark is here, around here. But there is local swelling, bleeding is there. Compared to this limb is swollen, bleeding. You can see blood oozing out. Blisters, small white, black swellings, which are blood filled. Blood filled blisters will be there, and you can see black tissue. These are gangrenous or necrotic tissue. You can see in the inferior part or posterior part of the calf. Then pain at the bite site. Obviously, the patient will develop pain because of necrosis and hemorrhage and severe bleeding. This can lead to compartment syndrome. So compared to this limb is swollen and shiny. So this is a cough compartment. This can lead to compartment syndrome where you have to immediately release the pressure and step, or if needed, you can, if the necrosis is too high and it is too long, it can even lead to complete cutoff of blood supply to the lower section of the bite mark, and you may need to amputate that part of the limb. Then peripheral, due to severe compartment syndrome or swelling or hemorrhage, there can be absence of peripheral flush below the bite mark, and nerve fibers can also get compressed, leading to hyposthesia. Due to compression, lymph drainage can get affected in the limb, and the upper lymph nodes can have backlog and will be having a lymph node engorgement. Here in case you can see the patient is having gum bleeding following a viper bite. Here it is not local manifestation, this is systemic manifestation. Patient starts to bleed from other orifices, especially from gums. So visible systemic bleeding from the action of so these venoms, vasculotoxic venom will have hemorrhagin. Hemorrhagins are those proteins will lead to endothelial damage and will start the blood vessels to leak. So the patient will have gingival bleeding, epistaxis, ecchymotic patch, wherein ecchymosis in patches groups along the muscle fibers will be there. Patient can develop vomiting, hematemesis, hemoptysis, even bleeding from rectum, subconjunctival hemorrhage, and continuous bleeding from the blood side. There will not be clotting mechanism happening, or and antiplatelet action, platelet action will be stopped, more of antiplatelet action, and coagulation also will be deranged. Then bleeding from pre-existing condition. For example, if the patient was having hemorrhoids or having a wound anywhere else, he will start bleeding from the freshly healed wounds also. Now the patient can also have asymmetric pupil. If the patient is having asymmetric pupil, it is not due to neurotoxic or neurotoxic envenomation. It is due to intracranial hemorrhage, wherein the pressure is causing unequal or anisocoria or asymmetrical pupil. Then there can be local swelling and pain, as mentioned previously. Some patients can present with locked-in syndrome. What is locked-in syndrome? It is defined as quadriplegia, where the patient is completely palsy from the neck onwards, and ananthria. With this, patient cannot move his limbs or anything, or even respond to his oral commands, or even blink, or even can turn his head. So complete paralysis with preserved consciousness. Now the patient can listen to you. but he cannot respond to you in any meaningful way. That is locked-in syndrome, wherein the patient's only response that is present is vertical eye movement. Apart from that, all other movements or muscle actions are paralyzed. So the only way to communicate with him is yes or no. So if he moves his eye up, you can tell him as yes, and if he moves his eyeball down, it is no. So by using this method, you can actually speak with the patient. This is non-verbal communication. In complete locked-in syndrome, patient cannot communicate in even any form. That is called central locked-in syndrome. That is due to damage in the ventral pons. The ventral pons lesion or hemorrhage in those areas lead to central locked-in syndrome. Peripheral causes of locked-in syndrome are acute polyneuropathies such as due to OPCs, neuromuscular junction blockade (NMJs) due to myasthenia gravis toxins and snake bite. So snake bite will cause mostly peripheral type of locked-in syndrome where there will be preservation of vertical gaze. Then confirmatory tests like EEG, where you can see the brain activity, which will be preserved, and cerebral blood flow, which will be normal, used especially to the MCA territory. We measure in the MCA. Then nerve conduction velocities to be done to avoid misdiagnosis of coma or brain death, because patients in coma or in brain dead state will resemble a locked-in syndrome. But the only thing is he has preserved consciousness and he can understand whatever you are saying, but cannot respond in any meaningful way. So what are the various other life-threatening complications of snake bite? Patient can have acute kidney injury, especially due to myotoxic, where the muscle fibers once lysed will lead to excess creatine kinase and other proteins, which will get deposited in kidney and can lead to ATN, acute tubular necrosis, and acute kidney injury. Then rapid rhabdomyolysis also will lead to acute kidney injury. Then hypotension due to hypovolemia or direct vasodilation or direct cardiotoxicity can aggravate this acute kidney injury. So patient can develop cardiotoxic due to vascular toxic, and the heart cannot pump properly, which will lead to stagnant type of failure or distributive shock failure. In that patient, there will be hypovolemia and there can be vasodilatation. This vasodilatation hypovolemia can lead to acute kidney injury. Then patient can also have parotid swelling, conjunctival edema, conjunctival hemorrhage, subconjunctival hemorrhage, renal failure, acute respiratory distress syndrome, otherwise known as ARDS, which was commonly seen in COVID, wherein the protein gets leaked because of damage to the endothelial connective tissues. So same thing, it can also happen in snake bite, wherein the lungs start leaking fluid into the alveoli, and refractory shock, extreme shock, which cannot be revived with just fluids or drugs. Then long-term sequelae can also be present, such as pituitary insufficiency with the Russell Viper's poison, otherwise known as Sheehan syndrome, where the patient will present with amenorrhea and cannot conceive normally due to absence of secretion of gonadotropins or gonadotropin stimulating hormone from pituitary. Coming to the third type of poison, that is myotoxic, as I already told, can have muscle aches, muscle swelling, involuntary contractions of the local muscle, and passage of dark brown urine, which means rhabdomyolysis has set in, and this has led to deposition of protein in the kidney. Protein has undergone ATN, and it is sloughing off all the nephrons into the, leading to cola colored or dark brown urine. The patient is having acute renal failure. Then compartment syndrome, as this muscle swells and then increases in size, can lead to compartment syndrome. Sometimes myotoxic can also affect the cardiac muscles, leading to arrhythmia and hyperkalemia. And as already mentioned, acute kidney injury. And sometimes mild neuroparalytic, or that I mentioned before, mixing of symptoms can occur. So the patient has come, you have identified the signs and symptoms. Now what test you want to do? You can do a bedside 20-minute whole blood clotting time test, wherein you take the sample of a patient as the patient arrives, and you keep it in a test tube undisturbed for 20 minutes. The blood has not clotted, venom-induced consumption of coagulation factors have occurred, and it is a patient is having coagulopathy. And if by the time neurotoxic envenomation is present, there will be signs of neurotoxic envenomation, and you classify as neurotoxic envenomation. If it is not there, you classify as vasculotoxic. So prothrombin time, platelet count, clot retraction time, all these things can also be tested. PT, platelets, clot retraction time. To find out other organ dysfunction, you go for liver function test, renal function test, serum amylase for pancreas and parotid swelling, and blood sugar level. ECG to rule out arrhythmias, abdominal ultrasound to rule out hemorrhage, and 2D echo for cardiac function. Urine examination for albumin and blood by dipstick to rule out acute kidney injury due to myotoxin or vasculotoxin. So in neuroparalytic envenomation, you do ABG and PFT, wherein pulmonary function test enables whether the patient immediately requires intubation and other treatment modalities, and ABG to rule out hypoxic-induced hypotension and tachycardia, and other hypoxia-related complications. In vasculotoxic envenomation, for coagulopathy, you rule out coagulopathy by doing BT, CT, or bleeding time, clotting time, prothrombin time, activated plasma thromboplastin time, platelets count, serum fibrinogen, fibrogen degradation products, D-dimer assay, LDH or liver enzyme, and peripheral blood smear. It all looks around uses of coagulation factors, bleeding abnormality due to platelet consumption, and D-dimer assay to rule out increased chances of clotting elsewhere. So you can come at a complete image of DIC with this help. Then hemolysis. For hemolysis, you go for urine myoglobin assessment and urine hemoglobin assessment. Cardiotoxic, so you go for all TROP-T, TROP-I, CKMB, 2D echo, and brain natriuretic peptide factors. For myotoxic, you go for creatinine kinase, AST, or creatinine level, uromyoglobin, and compartment pressure syndrome in case if it is a localized swelling. For infections, you rule out infections by doing assessment of serum procalcitonin, lactate, cultures from the site of infection like blood, urine, and wound. And after culture, you go for sensitivity. So superseded, so infection over the snake bite can also be ruled out, because if the patient had a snake bite, it is a the snake can also harbor some other bacteria over the fangs, and it can also lead to secondary infections. So suppose a patient has come with a suspected snake bite. So it can either be an overt bite or an occult bite. In overt bite, that means the bite mark is visible. There is history of non-venomous snake bite in 70%, only 30% are poisonous snakes. In occult bite, there is no history of bite, but it is mostly seen with crate. Crate will be biting only during night time, and it is usually seen in the thatched huts. So it can come down from the thatched hut during night, and the patient is sleeping, it will go and bite the patient and come out. The patient will not be having any pain. It is fang marks are so thin and it's not usually visible. This is called dry bite. And even in these patients will develop neuroparalytic symptoms and with no local signs and severe abdominal pain and vomiting. So in these patients, you suspect great bite, you start an anti-snake venom therapy and atropine neostigmine in the infusion, and intubate and electively ventilate if the patient is developing respiratory paralysis and respiratory failure. Now coming to overt bite, it can be asymptomatic or it can be symptomatic, or it can also be dry bite as already mentioned. If the patient is asymptomatic and dry bite, there is no bite marks and is asymptomatic, mostly it is due to sympathetic overactive. Patient will present with anxiety, palpitation, tachycardia, tachypnea. You just observe for 24 hours like any other snake poison patient. But if the patient is actually having symptoms, predominantly symptoms can be either a simple progressive swelling in the leg or the limb where it is bitten, or the site where it is bitten, or it can be a neuroparalytic site type of poison, or vasculotoxic, or a myotoxic. So depending upon the different types of poison, the patient can manifest with different types of symptoms. You can see various symptoms that we have mentioned before, like necrosis, ecchymosis, blistering, 5 Ds and 2 Ds and 2 Ts, and bleeding, the whole blood clotting time, muscle ache, involuntary contractions, and everything. So in all these patients, for example, in viper bite, where there is progressive painful swelling, you go for anti-snake venom therapy. Whereas in cobra bite, you just go for ASV, as mentioned before, even if it is occult or overt bite. Cobra arcade, you go for anti-snake venom therapy, followed by or immediately also start on atropine neostigmine to counteract the neuroparalytic effect and electively ventilate if there is respiratory failure. In hemotoxic or vascular toxic snakes like resistant snakes, sask-tailed vipers, you start an anti-snake venom therapy. Also provide supportive therapy, and to remove the DIC products and other envenomation, go for dialysis, and if required, if the patient is bleeding heavily, go for transfusion, blood transfusion as necessary. In myotoxic, you give anti-snake venom for any other and supportive therapy to avoid pain and compartment syndrome may require surgical and emergency management. And to remove the toxin, dialysis can be advised. So dialysis is advisable in vascular toxic and myotoxic patients. So coming to anti-snake venom therapy. So it was introduced by Albert Calmite. It is an immunoglobulin FAB2 fragment of IgG, and usually obtained from horse, mule, or donkey or sheep after being immunized with venoms of one or few species of snake. So it can be either monovalent or polyvalent. In India, we have only polyvalent snake venom, anti-snake venom. So in India, the more commonest snake are Indian cobra, Indian krait, Russell's viper, and sask-tailed viper. So we have a polyvalent vaccine, venom serum, which involves antivenoms against all these 4 common snake varieties, usually raised in horses. There are two forms of presentation. Either it is lipophilized or liquid form. In lipophilized, it is usually just be stored in a dark place and can even last up to 5 years because it is powdered form. Whereas in liquid form, it has a shorter lifespan and it has to be stored in 4 degrees Celsius cold storage. So indications for antivenom. So there is hemostatic abnormality. Patient is bleeding spontaneously from various sites. Or the patient's PT is more than 4.5 seconds, or INR is more than 1.2 seconds. There is thrombocytopenia, severe thrombocytopenia of less than 1 lakh. And patient is having positive whole blood, 20 minutes whole blood clotting time. So these patients are symptomatic of hemorrhage and they need to be actively started on anti-snake venom. Neurotoxic, same. So patient develops neurotoxic signs or cardiovascular abnormalities such as hypertension, shock, arrhythmia, or any abnormal ECG. The patient develops renal failure or if there is rising in urea and creatinine. So, and hemoglobin urea. So cola colored or dark colored urine, hemolysis, rhabdomyolysis, generalized muscle ache, pain, tenderness, swelling, bleeding from the site, and even auto amputation of digits below the bite mark, which indicates the patient is developing localized swelling and developing compartment syndrome. So antivenom treatment should be given as soon as possible and is indicated within first few hours of the bite. It may reverse systemic envenomation. Lipolysed antivenoms need to be reconstituted and usually done with 10 ml sterile water. There are 2 methods of administration, either intravenous bolus or push or intravenous infusion. In bolus, you reconstitute the lipolysed form of antivenom or liquid antivenom and given as a slow infusion, whereas in slow bolus, whereas in infusion, it is diluted in 5 ml isotonic fluid per kg body weight and then infused over 30 to 60 minutes. So what is the dose for neuroparalytic snakebite and vascular toxic snakebite? For neurotoxic, you take 10 vials of anti-snake venom and give it a stat over 30 minutes. Then you follow it with a second dose of same 10 vials after 1 hour if there is no improvement within the first hour. For that is for neuroparalytic. For vascular toxic, 2 low dose infusion therapy and high dose intermittent bolus therapy are available. So It can be either a low dose infusion where 10 vials of Russell Viper specific or 6 vials of saw-scaled Viper anti-snake venom are given as stat infusion over 30 minutes, followed by 2 vials every 6 hours as infusion in 100 ml of normal saline till the clotting time normalizes, or for 3 days, whichever is earlier. Whereas in high dose intermittent bolus, you take 10 vials of polyvalent anti-snake venom stat over 30 minutes as infusion, followed by 6 vials 6 hourly as bolus therapy till the same clotting time normalizes or swelling subsides. So what are the common side effects of anti-snake venom poisoning? Patient feels generally better with relief from nausea and vomiting. So patient feels generally better with relief from nausea, headache. Spontaneous systemic bleeding stops within 15 to 30 minutes. Blood coagulability is usually restored in 3 to 9 hours. Blood pressure increases in 30 to 60 minutes with arrhythmia reverting to sinus rhythm. So neurotoxic envenomation post-synaptic type begins to improve within 30 minutes after antivenom administration, while presynaptic may take several hours to get restored back normally. Active hemolysis and rhabdomyolysis cease immediately and urine color returns to normal within few hours. But in some patients, within 1 to 2 days, there can be recurrence of systemic envenomation. So this is due to complete, there is absorption of venom from the bite point. So redistribution of venom from fat tissues into the vascular space, re-entry can occur in 1 to 2 days. So you have to observe for 2 to 3 days, even after starting ASP, as patient can develop again symptoms of envenomation. So AS to be stopped when the bleeding subsides or reversal of the neurotoxic features or local progression, swelling progression is stopped. So in case of pregnancy and children, in pregnancy, pregnant women are treated same as any other patient. There is no change in ASV. Similarly, children also given the same dose. In infusion, liquid or lipophilized anti-snake venom is constituted in 5 to 10 ml instead of 5 ml per kg body weight. Then this means that there is no change in anti-snake venom dosing even in pregnancy or children. Anti-snake venom dosing in victims requiring life-saving surgery. The patient is about to have life-saving surgery. Intracranial bleed can occur in vascular toxic poison. So in this case, the patient has to be taken up for surgery. So in this case, you have to give anti-snake venom early to avoid increased bleeding risk and hemorrhage. So initial dose will be higher, up to 30 vials. Instead of 10 vials, you can give up to 30 vials, can be administered. So when to repeat the dose of ASV? So in the case of vascular hemotoxic, repeating every 6 hours until the coagulation restores to normal. But we have to give only after repeating clotting time test. In neuroparalytic, initial dose of 10 ml stat followed by second dose of 10 ml stat with no improvement over the first hour. Then repeat the second dose. Second dose may be required after 2 to 3 hours if again the signs of neuroparalysis have regained or started. So maximum dose is 20 in case of neuroparalytic envenomation. Even though anti-snake venom is life-saving, it too has so many adverse reactions. So reactions can be seen early within few hours or late even after 5 days of giving anti-snake venom. The risk of these reactions are dose related. So 20 to 60% of the patient treated with anti-snake venom will develop either a late or early mild reactions. But in some cases, there can be severe anaphylactic reaction that is due to IgE mediated hypersensitive type 1 hypertensivity. There is no test dose. There is no test dose for anti-snake venom therapy reaction. Only I have to give, the patient develops the reaction, you stop it. So what are the early anaphylactic reactions? Usually starts within minutes to up to 3 hours after starting ASV. Will develop itching, urticaria, dry cough, fever, nausea like any other anaphylactic symptoms, mostly of mild type. Patient can also develop severe hypotension, bronchospasm, and angioedema. This is all due to mediated by IgE mediated, and it is a severe anaphylactic reaction. Complement activation of the IgG aggregates, because IgG is what we give FAB particle, fragment AB particles of IgG, anti-snake venom is what you are giving. So the complement activation resulting from this can lead to mast cells stimulation and basophil, which can lead to severe anaphylaxis type of reaction also. Pyrogenic reactions, that is fever related, usually develops within 1 to 2 hours, 2 hours after the starting of anti-snake venom. Usually starts with small chills and rigors and can even lead to severe hypotension. It is due to contamination of anti-snake venom by pyrogens during manufacturing process. Late, which is serum sickness type, that develops 1 to 2 days, as 1 to 12 days or even a week later after starting treatment. Usually presents with fever, nausea, vomiting, mostly asymptomatic features like diarrhea, vomiting, itching, urticaria, complex nephritis, and even encephalopathy can come due to serum related reaction. So treatment of early anti-snake venom reaction, stop the anti-snake venom temporarily, give oxygenation, give a new IV line and start with a new IV set, give IV fluid. And before that, give adrenaline 1 in 1000 dilution, 0.5 mg in adults intramuscularly over deltoid or over thigh. In children, 0.01 for 0.01 mg per kg for early anaphylaxis and pyrogenic anti-snake venom reactions. You can also give chlorpheniramine maleate intravenously, either 10 mg for adult or 0.2 mg per kg for children. For high-risk patient, give ASV only if the signs of systemic envenomation of patient. Do not give for every patient with snake bite. And you can give before giving anti-snake venom injection hydrocot 200 mg and chlorpheniramine maleate 22.75 mg prior to giving ASV. If the patient presents after a week with a late reaction such as serum sickness, can give chlorpheniramine maleate 2 mg in adults for 6 hourly for 5 days. And if you fail to respond to chlorpheniramine maleate within 1 or 2 days, should start a 5-day course of anti-inflammatory and anti-steroids such as prednisolone 5 mg 6 hourly in adults and 0.7 mg per kg per day in divided dose for children. So pre-medication with adrenaline. So routine prophylaxis recommended for ASV because ASV is notorious to cause anaphylactic type of reaction due to the IgG antibody present in the anti-snake venom. So if the patient's BP is more than 140/90, it is and if a known hypertensive, it is better to avoid epinephrine prophylaxis. In other cases, you can give epinephrine at 0.25 mg of 0.1 solution by subcutaneous route. In case of children, it is 0.005 mg per kg of 0.1% solution. Histamine, corticosteroids, and rate of IV infusion should be 10 to 20 minutes. These things, even when given, do not affect the incidence or severity of the early reaction. So what are the contraindications? There is no absolute contraindication. The patient is having snake bite, it is better to, and is having envenomation signs, better to start on anti-snake venom therapy. But patient who have already have history of reaction to vaccines such as tetanus vaccine, rabies vaccine, or strong atopic disease, these are prone to develop severe reactions. Hence, it is better to have constant monitoring in this patient. And one should be given only when the signs of envenomation present. So complications due to treatment, death may occur due to airway obstruction, due to angioedema, aspiration, or respiratory failure. So you should always have a clear airway and may require intubation. The patient is having respiratory failure. Once there is loss of gag reflex or central nervous envenomation, patient will not have the sensation to cough out. The patient will have secretions getting aspirated and risk of aspiration of own secretions are high. And cricothyroidectomy is done in case the patient is having severe angioedema and unable to reduce with IVR in intratracheal epinephrine. So hypertension will be corrected by IV fluids, by usually crystalloids. May require inotropic supports or invasive monitoring as the degree of hypertension or severity is increased. So patient can have ophthalmia due to cobra venom spit. The cobra can spray the venom over the patient's eye, can lead to ophthalmia, and it is corrected by usually topical antimicrobial or 0.1% adrenaline will relieve the constricted type of pain due to cobra poison. If the patient develops necrosis, debridement is to be done of the tissue, dead tissue. Compartment syndrome, if the pressure is more than 30 mm as the patient is having a compartment syndrome, better to elevate the limb, administer 1 to 2 mg per kg of mannitol. And if none of this reduces, better to do fasciotomy to reduce the pressure. So managing neurotoxic poisoning, give oxygen, assist ventilation if the patient is unable to breathe, administer atropine neostigmine, initial dose of anti-snake venom to be administered over 1 hour, atropine 0.6 mg followed by neostigmine 1.5 mg to be given IV stat, and repeated dose of neostigmine 0.5 mg with atropine every 30 minutes for 5 doses. And in case of children, the dose is 0.05 mg per kg followed by a neostigmine, which is 0.04 mg per kg. And repeat doses neostigmine is 0.01 mg per kg every 30 minutes for 5 doses. To be given as tapering doses at 1 hour, 2 hours, 6 hours, and 12 hours. This improvement if seen with atropine neostigmine, it is usually due to cobra bite. In crate bite, there is no improvement with atropine neostigmine. Then crate affects presynaptic fibers where calcium ions act as neurotransmitter. So injection calcium gluconate 10 ml IV and in children 1 to 2 ml per kg slowly over 5 to 10 minutes every 6 hourly and continue till neuroparalysis recovers, which may last even for 5 to 7 days. So in case of crate poisoning, atropine neostigmine regimen will not work, and crate affects the presynaptic fibers, which are calcium ions. So you may need to give calcium gluconate to stabilize this nerve fibers. Then coming to management of vascular toxic snake bite, here you need to give strict bed rest, screen for hematuria, hemoglobinuria, myoglobinuria with dipstick method, maintain adequate minimum output of 1 mg per kg per hour, transfuse blood or fresh frozen plasma if required. Then recognition of organ dysfunction and immediate intervention. Then in adults, you can give fluid challenge, 200 ml of saline in 5 minutes and check for BP response. If positive, fluid given over 30 minutes or until the JVP, central venous pressure, is risen by 8 to 10 mg above the sternal line, 10 centimeter above the sternal line. Then FAD or post-alkaline diuresis. You give furosemide 40 mg IV stat followed by normal saline 500 ml with 20 ml of sodium bicarbonate over 20 minutes. Then follow it by injection regulator IV fluid 500 ml plus 20 ml of sodium bicarbonate over 20 minutes. Then change to 5% dextrose 500 ml plus 10 ml of potassium chloride over 90 minutes. Then inject mannitol 150 ml over 20 minutes. This will flush out all the toxins due to forced alkaline diuresis. Then if the patient presents hyperkalemia, which is more than 7 millimoles per liter, or there is ECG changes related to hyperkalemia, then give 10 ml of 10% calcium gluconate for stabilizing. Then give 50 ml of 50% dextrose with 10 units of soluble insulin to push all the calcium into potassium into the cell. Then sodium bicarbonate by slow IV infusion and salbutamol aerosol by inhalation can also be used to push the potassium into the cell. Then severe acidosis, patient will present with small breathing, rapid deep breathing, very low plasma bicarbonate level at pH of less than 7.1, severe acidosis. In this case, administer 2 to 3 ampules, 40 ml of 8.4% sodium bicarbonate equivalent to 1 millimoles per ml in 5% dextrose water, or half of the calculated deficit can also be replaced in 3 to 4 hours. If no clinical improvement is seen, dialysis is indicated. The patient present with shock or myocardial damage. The correct hypotonia with colloids or crystalloids, infusion of isotonic crystalloids of albumin, inotropic support with dopamine or dobutamine. In sepsis, noradrenaline is a drug of choice and it has to be started if the patient develops hypovolemia or hypotension due to septic shock. Then prescription plasma administered after anti-snake venom results in more rapid restoration of clotting function. If the PCV is lower than 30, blood transfusion is required. So these are my references for this article from the Ministry of Health and from Emergency Medicine and Toxicology reference book and WHO guidelines. Thank you for listening to my lecture. If you have any doubts or any questions, I'm free to The podium is free to answer. No questions are there? I can finish my presentation. Thank you.